Thanks very much for inviting me back to your forum to talk about one of the posters we had at EULAR. This was a poster titled "The Herpes Zoster in the Filgotinib Rheumatoid Arthritis Program," and is paired to another poster, another oral presentation we had on serious infections and infections in the filgotinib program. The background to this, of course, is that filgotinib is a JAK1 preferential inhibitor that has now been licensed in Europe and Japan. Across the class of JAK inhibition, we have been very aware about an excess risk of zoster and herpes zoster reactivation with shingles, and so we wanted to look in the clinical trial program. If you look at the poster, you can have a look at the study program we've recruited from. So we've looked at data from the phase 2, the Darwin trials, 3 of those, and then the 4 Finch trials that make up the phase 3 trial program. So we've pulled together the data from across those trials to present this abstract. The model that we use for doing this is looking at events that have occurred while people on treatment. So when you look at typical efficacy studies from clinical trials, we'll normally do intention to treat models. But in safety analysis, you don't want to do that because you don't want to attribute events when someone's not actually on the treatment. So we tend to use per protocol models when we're doing safety analyses. I think when you look at it, if you look at the poster, you can see the explanation of what we do with attributing adverse events that occur while someone is actively on the drug up until 30 days after they stop the drug, or in the studies in which they could switch up until the day before they switch onto a new treatment. We looked at first time to first event as our primary analysis, but we did also look at recurrent zoster, and you can find that data in the slide, in the poster. When you look at the results, it's always crucial if you're trying to interpret clinical trial data to look at the baseline characteristics. Because of space, I haven't put all the baseline characteristics in the slide, but there is a QR code that you can click on, and that will take you to the full baseline characteristics of the trial program. They're as you'd expect. So average age, early 50s, a female predominance, substantial level of baseline disease activity, DAS scores just below 6, significant amount of disability reflected in moderately high HAC at present at the baseline as well. When you look at the event rates, some very expected things. So the event rates were definitely associated with age, so increasing age associated with a higher rate of zoster across the trial program. When you look at the events broken down by group, well, the first thing to say, there were in total just over 100 zoster events in the trial program, and they were spread across the treatment arms. In the filgotinib 200 milligram group, that made up 74 events, so 3.3% of the population, 1.4% in the filgotinib group, 0.6% in the adalimumab group, 1% methotrexate, 0.4% in the placebo group. And actually clustered within that, there were 8 individual patients who had reported multiple events. 5 of those in the filgotinib group, 4 in the filgotinib group, 1 in the placebo group who had multiple episodes of zoster, and then 3 people, all 3 of them in the filgotinib group, who reported the same event multiple times. And that's because they reported the same event was reported with different grades of severity for the single episode. Most events were moderate and non-serious. So there are only 6 serious events, 2 of which were recurrences, and both of those recurrences were in the 200 milligram arm. But in terms of the vast majority of these events, they were non-serious events. And what's quite useful to think about is what happened to the filgotinib treatment. So of the 6 serious events, filgotinib was withdrawn from 2 of the people. It was interrupted in 3 of the people, and for 1 of the person who was actually only on 100 milligrams, the dosing continued throughout. And I think that's quite a useful remembrance, that, and we've seen this with the other JAK inhibitors, that many people elect to stay on treatment or just only transiently interrupt treatment for a zoster event. The challenge is who is it who's going to get zoster? So we did look at this, and you'll see in table 4, we've looked at what were the predictors of zoster in a univariate model, and then in figure 1, there's looks like a sort of forest plot of a multivariate model. And really one of the striking things was that prior history of zoster was a really important predictor. That's not a shock, but really important if you're starting people on JAK inhibitors prior zoster history is important, because there's this bizarre thing that you may think, oh, because they've had zoster before, they must have built up some immunity, and so that's a good thing, but it's not. It's the other way around. If you've had adult zoster, then your chance of getting it again if you start a JAK inhibitor is higher. The other thing was there's regional variations. In the right-hand column of the poster, we looked at the geographic breakdown, and similar to other JAK inhibitor studies, we saw this increased risk of zoster, particularly in Asia. Figure 3 in particular, if you look at it, shows the cumulative probability of zoster over time, and the standout numbers, which actually in the Asian program, we only went out to 24 weeks because we didn't enroll to the phase 2 trial program in Asia, but there is this standout apparent difference, which we've seen with other JAK inhibitors. I'll leave it there. Thank you very much for listening, and also have a look at the overall infection poster, which is paired up with this one, which is poster, it was an oral presentation number 126.